Hello, and welcome to the first in a new series of PodMedic's podcasts on clinical examination skills. My name's Stephen Wing, and throughout this series, we're going to be taking a systems-based approach to clinical examination. And far from definitive, the aim of these podcasts is to provide you with a framework that you can use to further develop your own style and clinical examination sequence. We're going to discuss the key concepts in clinical examination. We're also going to introduce you to the major clinical signs you should be aware of. We'll also try to pass on any tips that we've learned from our experiences on the wards and in exams. In this first podcast titled An Introduction to Clinical Examination Skills, we're going to do just that and introduce the purpose of the clinical examination. We're going to discuss how to approach a patient, how to get started, what to do during the examination, how to finish your examination and present your findings. We'll also touch briefly on objective structured clinical examinations, or OSCEs, and we'll also discuss how to improve your examination skills and exam technique. So the clinical examination forms one of the key phases of your clinical encounter. The examination should complement your history and not only allows you to confirm your diagnosis, but also provide some additional information such as etiology. For example, if you have a history that is compatible with heart failure and on examination you find a narrow pulse pressure and an ejection systolic murmur that radiates to the carotids, then your provisional diagnosis could be heart failure, secondary aortic stenosis. The clinical examination may also reveal other important information such as comorbid conditions that the patient perhaps doesn't have any symptoms of, and helps you form an overall impression of the patient, and this will inevitably guide your investigations and management strategy. So here are some useful pointers when it comes to learning clinical examination skills. Often amongst students, there is a view that there is a dichotomy between learning what you need to learn to pass your exams and also learning what you need to learn to practice medicine well as a doctor on the wards. But in reality, your objectives should be the same for both, and by learning the sequence of examination well and practicing on lots of patients looking for clinical signs, this should put you in good stead for being an effective doctor on the wards, and also you should pass your exams with no problem. There really is no substitute for a good history, and on the wards your history or in exams your lead-in will provide the clues to what you should look for on clinical examination. It's also extremely important to be systematic to ensure no steps are missed, and once you have a system, whichever one you choose, this system will develop with you as you become more experienced. But to allow this to happen, it's also important to be consistent and use the same approach every time. The idea of clinical examination is to use your senses to identify disease. So when you're examining patients, try to ask yourself, what can I see on inspection? What can I feel on palpation? What can I feel and hear when I percuss? And are there any particular odours that may be a hallmark of disease, such as the pear drop-like breath in diabetic ketoacidosis? Tasting your patients in exams or on the wards is not recommended. When in clinical situations, look out for your own safety and that of your colleagues. You can help do this by avoiding risky situations, by minimising any time you spend alone with patients, and when you do, make sure you tell someone where you are and what you're doing. Being accompanied by a chaperone is a useful way to look after your own safety, but also protects you from any false allegations. We'll explain later how to approach a patient, but it's really important to explain your role, who you are, why you're there, what you're doing, and also to maintain confidentiality. When you're with patients, try to be mindful of their comfort and dignity, and also understand that when a patient's not feeling very well, the last thing that they may want is someone doing extra examinations on them. If you're faced with difficult questions from patients, be that about diagnosis, treatment, or prognosis, it's extremely important not to put yourself in any compromising position and remind them of your role within the team. Explain that this information is better coming from one of the senior members of the team, and you could also offer to pass the patient's questions on to their junior doctor. Having said that, if your examination reveals anything that may be significant and would need to be considered in the care for that patient, you are obligated to share this with the doctors responsible for the care of that patient. It is in the nature of the beast that those with the best or most clinical signs are likely to be those who are most unwell. So when you approach a patient, it's really important to decide that very quickly, and you can use a technique called eyeballing. And really all this means is standing at the end of the bed and making some general observations as to whether that patient looks well or unwell. And your ability to do this will improve as you become more experienced and have more exposure to unwell patients. And as you may notice, some of your consultants seem to have a sixth sense or are able to smell disease from the end of the bed, and this is a demonstration of a very keen sense of pattern recognition that's brought about through many years of experience with patients. If you discover a patient is collapsed or looks very unwell, shout for help. Then check if there's any danger to yourself and approach the patient and check for a response. You can do this by giving them a gentle shake and shouting their name. If there is no response, then you need to check for breathing and a pulse for up to 10 seconds. If there is no breathing and/or there's no pulse, then this could be a respiratory, cardio, or a cardiorespiratory arrest. You should start CPR and call the arrest team. If there is no do not resuscitate order, if you're in doubt, start anyway, and you can always stop. However, if the patient responds to your calls and they still look unwell, you can perform an A to E assessment. Otherwise, apologise if they were sleeping. This next slide shows the Resuscitation Council UK's algorithm for assessing a collapsed or sick patient, and this and other guidelines can be viewed on their website. An A2E assessment is a rapid screening procedure that allows you to identify life-threatening problems that you should treat as you find them. Each letter in the mnemonic stands for a particular system, and these are displayed in order of importance, and any problems found in any particular system should be addressed before moving to the next one. For example, if a person has complete airway obstruction, high flow oxygenation would be pretty futile, and the primary goal in this situation is to remove the obstruction. A problem with the airway could be identified by any noisy breathing, and this may be in the form of snoring, choking, gurgling, or the patient could be stridulous. A stridor is a harsh inspiratory sound that suggests upper airway obstruction. However, in complete airways obstruction, there may be no breath sounds at all. Intercostal indrawing, recession, and accessory muscle use, along with the paradoxical seesaw respirations, are also suggestive of airways obstruction. If you find a problem with the airway, there are some simple but nevertheless quite effective interventions for helping relieve that obstruction. A head tilt and chin lift, or jaw thrust if there is suspicion of a cervical spine injury, can help relieve any airways obstruction by removing the tongue from the airway. Simple catheter or Yanker suction can be used to remove any fluids, and simple airway adjuncts such as a nasopharyngeal airway or a Goodell, that's oropharyngeal airway, can be inserted to hold the airway open. More definitive airways should usually be inserted by an anaesthetist, and these include a laryngeal mask airway or endotracheal intubation. If your patient's maintaining their own airway and this airway is free from obstruction, you can then move on to assessing their breathing. With breathing, there are three things that you want to know: whether there's any respiratory distress, how well is the patient oxygenating, and how well are they ventilating. Respiratory distress can be recognised from an increased respiratory rate and accessory muscle use. If you find respiratory distress, you should put the patient on high flow oxygen, 15 litres a minute, via a non-rebreathing mask. Oxygenation can be assessed by looking at the patient's colour to see whether there's any central cyanosis. You can also use a peripheral oxygen saturation probe to measure the oxygen saturation, but really an arterial blood gas is the gold standard in assessing oxygenation and also for ventilation. Ventilation can be further assessed by inspecting and palpating for equal chest movement and by listening to the chest to ensure equal air entry bilaterally. Having done all that you can do to improve the patient's airway and breathing, You can then move on to assessing their circulation. Firstly, you should take the pulse and note the blood pressure, but really circulation or cardiac output is best assessed in this situation by looking at end organ perfusion. You can assess peripheral perfusion by feeling for the peripheral temperature. If they're very cold, this may suggest a poor cardiac output, or indeed vasoconstriction to try and maintain a higher cerebral and central perfusion. You can also test the capillary refill time, and this is best done by pressing on the sternum for 5 seconds and then releasing, or alternatively, pressing on the nail bed of a finger held at the level of the heart for around 5 seconds and then releasing. The capillary refill time is the time it takes for the pallor to disappear, and this should be less than 2 seconds in normal subjects. You can also feel for the radial pulse, and this is usually strong when there is a systolic blood pressure of over 100 millimeters of mercury, and is rarely present in a strong way when the systolic blood pressure is less than 90 millimeters of mercury. There are two other organ systems that we can use their function as a surrogate measure of cardiac output, and those two organs are the brain and the kidneys. A decreased GCS could represent a poor cardiac output, as could oligoanuria. And again, with all systems, you should treat the underlying problem as you come across it. Assessing someone's disability is assessing their level of consciousness, and the word disability is only really chosen to fit the mnemonic. The gold standard measure of consciousness is the Glasgow Coma Score, which we won't go through here, although a rapid assessment of consciousness could be done by using the AVPU scale. And this is a scale where you grade someone as either being alert, responding to voice, responding to pain, or that they are unresponsive. Responding to pain suggests that there is a Glasgow Coma Score less than 8. You should also at this point ask for a blood glucose, as aberrations in the blood glucose level can cause decreased consciousness. The E in the A2E assessment stands for exposure and environment, and in this you should expose the patient looking for any external signs of life-threatening injuries, rashes, or any swellings. You should also take the patient's temperature and deal with any issues that may have arisen from any environmental exposures. So that's all the groundwork completed. Now finally onto our examination. This is how to get started, and I always find a useful mnemonic in the word help. It's important to remember that before we start any examination or we attend a patient, we should always wash or decontaminate our hands. The help mnemonic is invaluable in an examination settings, and make sure that when you're nervous, you get off to a good start. The H in the help mnemonic stands for hello, and in this you should introduce yourself to the patient, explain the purpose of the examination and what you intend to do, and also seek their consent for the examination. We'll come on to this later. The E stands for exposure. You should ensure adequate exposure of the body part or system you are going to examine. You should ensure that there's sufficient lighting. You should also position the patient appropriately. When introducing yourself, there are certain things we need to do to make sure the examination goes smoothly. This is best remembered by remembering the 3 words introduce, explain, and consent. Our introduction should include who we are, where we're from. We should also explain to the patient our role within the team and the examination procedure itself. You should also explain that the examination is for your education only, and that also you are bound by confidentiality. Although, as we spoke about earlier, if you find any useful information, you are obliged to share this with their doctor. You should then seek consent for the examination. The 3 pillars of consent are really that there is no coercion, that the patient has been informed, and that the patient is competent. Consent can either be implied by the fact of them offering your hand for you to examine, for example, or it can be explicit in the form of a verbal or written expression. Once those formalities are out the way, you can then move on to your end of bed inspection. There's another ABC approach I like to keep in mind to help you categorize and be systematic about the way you approach your end of bed examination. You can comment on their A, B, and C. Their appearance, you can comment on their general appearance, their body habitus, age, sex, skin, personal hygiene, anything you think is relevant. And then I like to do a top to toe or toe to top examination, looking for certain features such as any characteristic facies, any scars, truncal obesity, or signs of vascular disease in the lower limbs. The B stands for behaviour, and we can make comments on whether the patient is grimacing in pain. We can also make observations as to whether the patient is adopting any particular posture that may alert you to any underlying pathology. For example, peritonitis, patients may lie very still. If the patient is propped up in bed with many pillows, this may suggest orthopnea. Patients with pericarditis like to sit forward, and patients with difficulty in breathing may purse their lips. They may use their accessory muscles of respiration, and to facilitate this, they may also brace themselves on a solid object. You can then move on to C and comment on their connections, whether they connected to any 3-lead cardiac monitoring, any infusion pumps or oxygen. You can also comment on medical paraphernalia around the bedside, such as sputum pots or any medications like glycerol trinitrate sprays. During the examination, it's important to look slick and feel confident. This is more important during the exam setting, but on the wards and in clinics, it makes you feel at ease and also makes the patient more confident in their doctor's abilities. And as much as possible, get the patient to help you. Try to avoid over-touching the patient. If you simply want to look at their hands, you can ask the patient, "Can you put your hands out like this?" followed by you demonstrating what you would like them to do. This is certainly more preferable than trying to grab the patient's arms and throw them out in front of them. If the patient can't help for whatever reason, ask for a helper or a chaperone to help them sit up so you can listen to the back of their chest, for example. And during the examination, be sensitive to the patient's needs. In particular, pay attention to any pain and try to maintain their dignity at all times. With the examination, it's important to have a system like everything, and we'll show you ours in a moment, but be systematic and give yourself reminders and clues. And whilst you're examining, be observant, using all of your senses to try and pick up the clinical signs. The examination is traditionally split into different sections based on these senses. For example, inspection, you are looking, you feel when you palpate and percuss, you can also hear percussion, and you should also be hearing any noisy breath sounds with your own ears from the end of the bed, or any very, very loud murmurs or clicks from heart valves. You can also use mediate auscultation. This is using a mediator like a stethoscope. You should also note any distinctive odours. So here's our example of a scheme you should follow when conducting a clinical examination, and our system follows a traditional scheme whereby you start at the hands and work up to the top of the head, and then all the way down in the midline of the body to the feet. Bear in mind that you should develop your own system that you feel comfortable with, and also that different systems examinations require examination of different body parts. As we run through this scheme, it might be worthwhile you trying to imagine standing at the traditional right-hand side of the patient and looking at these different body parts. We'll firstly start by looking at the nails for any pitting or clubbing. We'll then go on to look at the hands for any deformity and noting the temperature. In the upper arms, we can measure the blood pressure. Moving on up to the neck, we should look at the JVP and carotid pulsations. We can look at the face and note the shape, the colour, complexion, or any defining features. We can look in and around the patient's eyes, in and around their mouth. We can then move on to the anterior neck, and we should be looking for any signs of goiter and feel for any tracheal deviation. And at this point, it should remind us that we should also look for any lymphadenopathy and palpate for lymph nodes in the cervical, submandibular, submental, supraclavicular, and in the axillae. We can then move on to the anterior thorax, where we should be inspecting, palpating, percussing, and auscultating, and again on the posterior side of the thorax, the abdomen. Then we can examine the lumbar areas and flanks, the external genital regions, and we can examine the legs, looking for perhaps petechiae or signs of vascular disease. We can also look at the feet. Using a system in this way is helpful because should you get lost during your exam, it's easy to use the patient's own body as an aide-memoire and tell you which region of the body you should go on to examine next. A nice finish to your examination should include thanking the patient, providing them any help with them getting dressed, again washing your hands, and then thinking of things that would complete your examination. This may include a closer inspection of a particular body part, or conducting an examination that you either didn't have time or the equipment to do, such as fundoscopic examination of the retina. At this point you could think of any simple bedside investigations and any further tests you would want to confirm your diagnosis. To help you, you could classify investigations into the 5 categories as Ed has mentioned before on previous podcasts. You could order cultures taken from wounds or from urine. You could also take blood cultures. You could take other venous bloods and send it for biochemistry or hematological investigation. You could also take arterial blood to measure partial pressures of gases. Any imaging you may want to order could include simple X-rays, CT or MRI scans, ultrasound scans, any scopic investigations such as a colonoscopy or a gastroduodenoscopy, or you could order biopsy investigations such as a lymph node biopsy or perhaps a bone marrow biopsy, and any functional tests such as an ECG or spirometry or an exercise tolerance test. Other mnemonics include the UBEC special mnemonic, which stands for urine, bloods, ECG, X-rays, and special tests. So now we move on to the nerve-wracking part of presenting your findings, and the key with this is to make it succinct and to also try to capture and maintain the interest of whoever's listening. To do this, you could provide a hook, and really all this is a lead-in with a few statements about the patient and who they are, and something interesting about them. This 76-year-old never smoker, or this 90-year-old nursing home resident. As with everything, it's good to be systematic, but also I'd say with presentation, you should decide early on what you think the most likely diagnosis is, and present your findings, clustering different signs to support that diagnosis. You should also try to refute any potential differential diagnosis, and I think this is really what makes a presentation interesting. Instead of a long list of positive and negative signs, you can group them together, and this helps to create a more cohesive story and also helps to maintain the interest of whoever's listening, and it's easy for you to remember. So an example of a presentation could be something like this. Mr. Smith is a 69-year-old retired police officer who presented earlier today with a 3-day history of shortness of breath. On examination, I found him breathless at rest with a respiratory rate of 30 and an oxygen saturation of 92% on air. He was warm and clammy to the touch. His temperature was 38.5 degrees Celsius. He was tachycardic with a regular pulse of a rate of 110 beats per minute. He was hypotensive with a blood pressure of 90 over 60 millimeters of mercury. His jugular venous pressure was not raised. His heart sounds were normal, and there was no peripheral edema. On examining his chest, I found decreased air entry in the right base, which was dull to percussion. I also heard coarse crackles over this region, and above this I heard bronchial breathing. The rest of the examination was normal, and my diagnosis here could be a systemic inflammatory response secondary to a right basal lobar pneumonia that was acquired in the community. So once you have your suggested diagnosis, you can then move on to the next 2 phases of your clinical encounter, which, if you remember from earlier, were investigations and management. Investigations in this situation could include, and we use our mnemonic as we discussed earlier too, any cultures. And here you would want to culture the sputum. You'd also want to send blood cultures. And there are no right or wrong answers. As long as you can make a justification for anything, you could also culture the urine, as this could be one of your differentials for sepsis. You could also send urinary antigens for Legionella and Streptococcus pneumoniae, and then you would move on to drawing bloods. Bloods you can split into arterial and venous bloods. You would certainly want arterial blood gases because the patient was hypoxic on room air. Also, they are septic and you would like to know whether there is a lactic acidosis because of this. Venous bloods you could split into the full blood count, the U's and E's, the liver function tests, and also the CRP. If you were thinking of any atypical pneumonias, and also if the patient was immunocompromised, you may want to order some other tests here. But initially, this is a good start. Moving on to imaging, you certainly would want a chest x-ray. Any scopic or biopsies at this point is probably unjustified until you've got further information. And functional tests, you might want to do an ECG because the patient was tachycardic. And then at the end you could give a few suggestions for management. Some of the obvious things you might include are oxygen and antibiotics. You would also suggest intravenous fluids and close monitoring of their vital signs. So now I just want to mention OSCEs very quickly. OSCEs are examinations that are favoured by medical schools because often they're the only way to test practical skills. OSCEs consist of stations whereby you rotate. You have a time limit for each station, and on starting a station you'll be asked to read a lead-in statement or a patient history. You'll then be presented with a task, and in the clinical examination stations there will be a patient for you to examine and also an examiner. The examiner will be marking your performance against a checklist, and at the end of the examination, provided you have enough points and provided you don't meet any absolute fail criteria, then you'll pass the examination. With examinations, you often get a point for washing your hands. It's also important to be polite and considerate because some medical schools give a point which is decided by the patient themselves as to whether they felt comfortable with you examining. It's often very difficult being an examiner, and examining the last candidate of a busy week of examinations can be quite stressful. It's important to help the examiner as much as you can. Be very obvious in your actions and be very deliberate, much in the same way you would when you're taking your driving test. And also it's important to try and lift their spirits a little by being confident and happy. The easiest way to look slick and be confident is by having prepared well, and you should aim to practice as much as you can in front of your peers and receive feedback from them. The most common difficulties in OSCE examinations is the fact that there's a time limit. You can often be very nervous. You may lose track, and this may increase your nervousness. And also people are worried about making mistakes, and when they do make a mistake, they don't manage it at all well. Some tips to avoid any problems during your OSCE is to practice examinations in a pressurised environment. You can simulate this with your colleagues by setting up a mock OSCE station. You can have someone who's doing the timing, and this will also serve to help reduce any nervousness. If you've experienced the feeling of what it's like to be in an OSCE, this will help reduce your nerves in the real exam. Taking a systematic approach should prevent you from losing your place in your examination, but having a consistent approach will mean that if you do lose your place, you are able to find your way from there. If you do make a mistake, it's important not to dwell on this, not to worry, correct the mistake if you can, but remember that the OSCE mark sheet is a tick list, and if you spend too long on one particular point, then you're not gaining any additional marks, and your time will run out. So it's important to keep moving on, and provided that you haven't met any of the major fail criteria, everything should be fine. So here are just a few tips on how to improve your skills. Observing others examining patients is an extremely useful way to improve your own examination skills. By watching others, you can often learn new, elegant ways to do things. You can view different techniques and different styles and decide for yourself what works well and what doesn't work well. And even if the examination is not particularly good, you can, and I suggest you only do this in your mind, fault find with their examination, and this also helps you to solidify your technique in your mind. You can also use their examination as a stimulus for you to generate any questions, and asking questions is another fantastic way to learn more about clinical examination skills and the signs that you may pick up. Above all, practice makes perfect, and by examining lots of patients, noting the normal and the abnormal, you'll be able to pick up more signs more readily. At the end of the examination, I suggest you review the examination you've just completed and also review your findings. This may allude you to any things that either you've missed on first pass, or any findings you find may suggest a diagnosis. You may want to complete other manoeuvres to help support that diagnosis. For example, if you hear a murmur, you may want to see if there's any postural change in that murmur, and you can also examine for any additional signs that may be associated with that particular diagnosis. Try to make comparisons between your examination findings and the findings of more senior colleagues, although remember that examination findings may change as the patient's condition changes. Try to follow up patients that you examine and correlate your findings on examination with the investigation results. For example, if you hear some crackles on the right base when you listen to someone's chest, try and have a look at the X-ray when it's completed and the diagnosis resulting from that. This is the only way you'll learn the exact nature of what you're seeing, feeling and hearing. So that brings us to the end of this introductory podcast on clinical examination skills. And just to summarise, we've talked through the purpose of the clinical examination, how to approach a patient, get started, what to do during the examination, how to finish and present your findings, and we've briefly spoken about objective structured clinical examinations or OSCEs, and we've also given you a few pointers on how to improve. In the following podcast, we'll be breaking the physical examination into body systems. We'll go through the framework and format of the examination and also discuss the clinical signs. Thank you very much for listening.